Yeah. So let's start. It's already late, but as I'm doing this accumulation of the recall, so as and when I'm trying to finish it off as soon as possible, so I can understand that all of you must be in a lot of stress right now. So today I'll be discussing 11 questions right now, and as and when possible, tomorrow I'll be trying to discuss more and more and trying to finish off the recall in the next. As and when you guys can come up with the questions and the options properly, it will be helpful for me to make a proper recall session for you guys so that it is easier for you to understand about your how did you go about the paper. So the first question that is about the paraneoplastic syndrome of the lung with hyponatremia and weakness. What is the diagnosis? So just a quick thing that in this recall, if you find that the question stem and the options which I am telling are not accurate, please mention so that it is easier for me to correct the key, because I don't want to create any issues which can make you lose marks or gain marks unnecessarily and make you demotivated or extra happy. So just make sure that you can correct me in this session right now if at all the question stem and recall what I'm telling is incorrect. So this first question, that is paraneoplastic syndrome with hyponatremia and weakness. So this is also straightforward from Schwartz. Now I have seen across that till now as I am going through the questions, I've seen that many of them are from Schwartz and Sabiston, and it is not outside of the textbooks, which I felt. And so if we go about this paraneoplastic syndromes, what is given is that the hyponatremia associated with SIADH and weakness, confusion, lethargy, everything is a part of small cell carcinoma. And if we talk about the notes, they have clearly mentioned this and explained this, that one of the important thing what you guys need to understand is the lung tumor strongly associated with paraneoplastic syndrome is small cell lung carcinoma. And another important thing is that more the neoplastic syndrome associated with small cell is SIADH and Cushing, which presents with hyponatremia, and Eaton-Lambert syndrome also, which is associated with muscle weakness. So this question answer is small cell lung carcinoma. Sorry, small cell lung carcinoma is the square answer here. So I hope the question stem and the options are okay in this. If you guys have any corrections or anything, just please feel free well to mention in the chat box. No, yeah, fine. Yeah, so next question, that is about a 35-year-old male with history of RTA, renal hilar injury was identified. I think this is also what you guys have told me, successful resuscitation, a hemodynamic unstable patient. So I think this is a very straightforward thing that in any patient with hemodynamic instability, or even for that matter, if you have any renal injury or kidney injury, especially with a trauma, you don't do any unnecessary odd incisions. You basically go in straight midline laparotomy. Okay, so instead of clamshell, it was subcostal. Okay. I'll go on correcting the options as well, even if the answer I am telling it as correct, because this will help you and even the next students to go through the previous year recall for them to prepare for the next year. So please correct whenever possible. So yeah, a renal hilar injury, hemodynamic unstable. I think this is a very straightforward question wherein any patient with trauma, you directly go in with midline incision. You do not do unnecessary flank or chevron or anything. You straightforward go in, because if you have to treat the vascular injuries, you may have to go for the metox or the cattle brush maneuvers, which can only be done with a midline laparotomy. So I think this is a straightforward logical question. And also if we go in the Schwartz, this is mentioned, and also we have clearly mentioned this is a combination of billion shots, which we have mentioned in our notes, power of notes, is that midline is used for trauma, and also the indications are given. And in that renal pedicle avulsion or any kind of hemodynamic instability, this is an indication for surgery, and surgical exploration we go with anterior midline incision. So I think the correction here was that the option was subcostal. So all the other option and the question stem is correct. So the answer here is clearly midline incision. Now, another important thing, coming to the next question, triangle involved when subclavian and brachial plexus is compressed, or in which anatomical structure will you see a subclavian artery and brachial plexus compression? I think the question stem is okay, and the options were scalene, costoclavicular, anterior, and occipital triangle. I think this is accurate recall of this particular question. So in this, it is again the thoracic outlet syndrome has been covered pretty much only in Savaston in the thoracic part. Yeah, so this is again straightforward from here. And even if you see in our notes, we have clearly given you the proper images where in the scalene triangle, you will see the subclavian artery and the brachial plexus going through that. In the subcoracoid space, you are having almost all the three structures, and the costoclavicular space, you are having only the artery and vein, and also that is what is mentioned. The subcoracoid has all three, costoclavicular has more often the vein, and here it is the interscalene or the scalene triangle, which is the correct answer in this. So any corrections in this question about any issues in the question stem or the options? Costoclavicular space was there in the option. Yes. Okay, fine. Yeah. So this is again a very important topic, and we have also thoroughly covered in our classes and also in the notes, wherein we have clearly shown you with diagram. So if the students you have seen this, you'll be easily able to answer this. And I think in the three questions which you have covered till now, these are very straightforward, and I think all of you must have done it correctly. Now, this is again a very straightforward question about the muscle involved in the given congenital anatomy with the figure given, which is showing a unilateral cleft lip. So I think this is also a proper image recall what you guys have given to us. So the options were orbicularis, buccinator depressor, and libitor labii superioris. Any correction in the question or options, please mention in the chat box. So I think this is a very straightforward again question in which the answer would be orbicularis oris. And again, in this is not very clearly mentioned about which muscle will be involved in the particular cleft lip, unilateral cleft lip. It is a generalized description and explanation which has been mentioned in the textbooks. But if you see the image what you have mentioned in this, you will see clearly that in the unilateral cleft lip, the muscle what is involved here is the you'll have the it is the orbicularis oris muscle. I think this is again a very straightforward question. So this is very clearly proper recall about the question and the options. So moving on to the next, that is which is not a management of thoracic duct injury. I think it was a straightforward question like this, or any mention of any scenarios given. And I think all the four options are also correctly recalled. So don't think there is any discrepancy in this recall. Yeah, so thoracic duct injury, which is not a management. Again, if we see, we have accumulated, this is again taken from Schwartz and Sabiston combination. If you have read this, either the textbook or from our notes, it will clearly, you will mention in this page that thoracic duct injury occurs leading to chylothorax. You will have to go for one will be you go for NPO with TPN, you go for a medium chain triglyceride diet, you give octreotide somatostatin. If it not, you go for either procedure will be a thoracic duct ligation. There is no concept of thoracic duct bypass. So I think this is again the correct answer here is thoracic duct bypass, because you either go for a thoracic duct embolization usually in IR, but the other treatment options are NPO, TPN, medium chain triglyceride, and a thoracic duct ligation. Okay. So again, I hope no issues in this question and the options. So this again moving on to the next, that is which of the following is not a criteria for ARDS. Now this is straightforward taken from Schwartz table, that is the inclusion criteria for the ARDS, which mentions it as the criteria should be that the onset should be acute. It should be there should be any predisposing condition. The PaO2 to FiO2 ratio should be less than 200 regardless of NEP pressure. Bilateral infiltrate should be there. The pulmonary arterial occlusion pressure should be less than 18, and there should be no clinical evidence of right heart failure, because that can also lead to the infiltrates. So I think the four options are correctly recalled here, in which the answer is clinically right heart failure. Any issues in this question stem or the options, please let me know so that I can correct it right now itself. So I think this was also a straightforward question with the particular option given. So again, as in this 6 or 5 or 6 question which I've discussed, I think I have come across 4 questions directly from Schwartz. So I think Schwartz is a major book now which they have been starting to asking in the last 2 years. So moving on to the next question, that is, so this is something where a recall has been slightly discrepancy is there. So please correct me right now so that I can give you a proper answer for this question, because any change in the options will slightly change the answer. So please let me know. The old patient, 65-year-old old ale patient unfit for surgery, was this the scenario, or only an old patient without any high risk or comorbidity was mentioned? So what was the scenario? Don't worry about this review sessions. In this video, I'll be uploading on the YouTube as well. So don't worry about that. Even if you have joined on late, I'll just quickly scroll through once I have covered today's 11 questions. Yeah, so 65-year-old. So the question was 65 oral patient, no high risk. Was there any mention of any instability or frail? So I think there was no mention of frail or unfit for surgery. Yeah, so no high risk. Okay, no high risk. Yeah, Nemo was there. Okay, yeah, okay. What are the options? What I have mentioned is correct. What were the options? Abdomen was showing localized tenderness over left iliac fossa. And in the imaging, I think pneumoperitoneum was mentioned. Pneumoperitoneum, fever. I think pneumoperitoneum was mentioned, right? Free intraperitoneal air was mentioned or not? Free air was mentioned, yeah, I think. So I think that is also what I got in the recall, that free air was given, or the free intraperitoneal air was given. That is pneumoperitoneum was given. So I think the question stem is slightly, now we have a proper recall wherein a 65-year-old, no high risk, free air or intraperitoneal or pneumoperitoneum with fever, localized left iliac fossa tenderness. And what were the options? Can you help me out with the options? What were the options given? I think with 7 centimeter localized abscess was given. 7 centimeter localized pelvic abscess. Okay. Yeah. So one option was extraperitoneal drainage with antibiotics. Right. Other was PCD drainage followed by elective colectomy. Okay. Hartmann's was one of the option. Right. So one option was extraperitoneal drainage with antibiotics, PCD drainage with IV antibiotics with colectomy. So okay, here we have followed by antibiotics followed by elective colectomy. Okay. So what was the fourth option as exploration drainage Hartmann's procedure with colostomy? Yeah, so this is what the option was given. Yeah, what was the fourth option? So Hartmann's with basically exploration and colostomy and colectomy. So extraperitoneal drainage is done. PCD drainage followed by antibiotics followed by colectomy is the other option. Hartmann's with the exploration and drainage and colostomy is the, and last option was observation alone. Okay, so I think all four options are now properly recalled. I think no issues in this. Observation with antibiotics. Okay, right. Okay, so now we have the complete question. That is a 65-year-old, no high risk features. Fever was there in the question. Was fever there in the question? Yes. Fever with localized left iliac fossa tenderness, pneumoperitoneum with a pelvic abscess, with diverticular disease. So I think this is again a straightforward. There is no doubt about this, that you don't do in such patients. If you can go for surgery, that is the best treatment for diverticulitis, complicated diverticulitis. So remember that if you go through Savastin or Schwartz for that matter, complicated means that there is pneumoperitoneum, there is a perforation, and perforation does not mean always that there is any fecal or purulent peritonitis. Basically, any perforation with pneumoperitoneum, basically you need to go for surgery, and the gold standard is Hartmann's procedure for complicated diverticulitis, specifically related to the pneumoperitoneum. So this is again very simple, straightforward. If you have read this from the, so it is not about being accessible to PCD or not. If this patient comes to me, being a GI surgeon, when this patient will come to me, I'll see that the patient is fit for surgery. There is no high risk features. He has a complicated diverticulitis wherein there is a abscess and there is free air. That means that the diverticulitis has perforated, but it has got localized, it has sealed off. But and the important feature is that there is tenderness and there is fever. So it is straightforward. In this patient, I'll go in for surgery. I'll not wait for antibiotics for PCD to see that the patient is stabilizing or not. I'll straightforward go in for surgery. If the question had that the patient is none fit for surgery or has comorbidities, I'll still evaluate the surgical morbidity and then go for PCD. But in this scenario, wherein you're not having any high risk features, the patient is having fever, there is localized tenderness, there is free pneumoperitoneum or free intraperitoneal air, I'll go in for surgery. And exploration drainage Hartmann's with colostomy will be what I will do in clinical practice. So I think this is again that in complicated diverticulitis, understand that Hartmann's procedure is gold standard and this will be emergency. And remember that if it is 65 or 75 nowadays, this old age patients are more fitter in terms of cardiac status than the 40-50 year old what we are getting right now in the clinical practice. But see, even if it is Hartmann's with colostomy mentioned or not mentioned, remember that Hartmann's procedure is actually a terminology wherein you remove the sigmoid, you do the rectal stump closure, and you do a end colostomy. So colostomy is a part of Hartmann's procedure. So even if colostomy was not mentioned in the option, if only Hartmann's was mentioned, still that will be the answer. Yes, correctly mentioned. So the answer here would be now very clear that it is exploration drainage with Hartmann's. So the correct options are as mentioned, that extraperitoneal drainage with antibiotics. I will not do PCD drainage, then antibiotics, then colectomy. No, that will also I'll not do. Yes, recurrent diverticulitis is there. And remember that if you have read properly Sabiston and Schwartz, and if you understand the concept of complicated diverticulitis, any one episode is an indication for surgery. Do not wait to stabilize or treat conservatively and then do it. It is not such. Complicated diverticulitis being perforation, bleeding, or even peritonitis, that is purulent peritonitis, you go in for surgery if you can. That is the best treatment for diverticulitis. So this is again clear. The answer will be exploration, drainage, and a Hartmann's procedure. Okay. So moving on to the next, that is a young female with a 2 by 2 breast. Yeah, number of episode is no more a strategy. Patient comes with a complicated diverticulitis, straightforward surgery. So next question, young female 2 by 2 breast cyst changing with menstruation seen on USG with a solid component. What is the management? So please help me out. It's the question stem and the, okay, they had asked for a next best step. So are the options correct in this? Yeah. So this is again breast cyst concept taken directly from the Bailey for that matter, that if you have solid cyst, that is a complex cyst, and you go in for a core biopsy. And even what we have correctly summarized also in our notes, wherein simple cyst is actually Bariatric 2, complex cyst is actually having solid component, you go in for core biopsy. So I think here we have no doubt that the answer should be core biopsy. This is a case of a complex cyst. Therapeutic aspiration alone, okay. Okay, observation. Excision was not there in the options. Okay, so it was observation, core biopsy, cytology of fluid or cytological examination of fluid, and aspiration alone or therapeutic aspiration. So I think these are the options here. So this is any doubt in this question and the options? Okay, yeah. So the answer here is core biopsy. Moving on to next, that is again there has been some discrepancy in the question stem here. That is a 35-year-old female patient with enlarged painless lobulated gland with features of hypothyroidism, wherein they had mentioned about menorrhagia, constipation, and histopathology was suggestive of Ashkenazi cells, or what are also termed as a Hurthal cells. What is the diagnosis? 2 by 2 centimeter benign cyst or the cyst with the solid component. Sorry, just going on to the previous question because one of you mentioned. I think here that mentioned with solid component. I think there is no doubt here, right? Yeah. Okay. Yeah. Yeah. So here they had mentioned about. I think you had mentioned cold intolerance from gland, weight gain. Okay. So all the hypothyroidism features were there, and histopathology was suggestive of Ashkenazi cells. So diffuse enlargement was there. Okay. Diffuse enlargement of the gland was there. No other features were given, only hypothyroidism, diffuse enlargement of the gland, Hurthal cells, or Ashkenazi cells. I think this is a kind of very straightforward question that the answer would be Hashimoto's disease. So if you see and read in the textbooks, there is no particular mention of follicles are lined by Ashkenazi cells. Right. Okay. Yeah. So, yeah. So here, if you see that they mentioned not very clearly, I could not find about very clear mention of Ashkenazi cells in particular, but we have mentioned everywhere that in the Hashimoto's thyroiditis, you have Hurthal cells on FNAC. There will be diffuse enlargement in the Hashimoto's thyroiditis. And see, you have to evaluate the clinical scenario wherein you have a young, middle-aged female with diffuse enlargement of the gland. You are having hypothyroidism. So this is classical presentation of a chronic lymphocytic thyroiditis or a Hashimoto's thyroiditis, and this is not a follicular Hurthal cell variant of the follicular cancer. So there is a differentiation in the clinical symptomatology of a patient with a follicular carcinoma with a Hurthal cell variant or a Hashimoto's, because if you have a follicular cell carcinoma with Hurthal cell variant, you should have classical presentation of a carcinomatous or the features of cancer with some capsular invasion, vascular invasion, and also the Ashkenazi cells. So here you cannot point. Okay, subacute, there was option of Graves. Okay, yeah, right. Okay, no subacute. So I think the options are clear. Hashimoto, Hurthal cell, Riedels, and Graves. So hypothyroidism, so Graves is eliminated, and even Riedels is eliminated for that matter. Now there is a confusion between Hurthal cell carcinoma and Hashimoto's, but the feature of the female age, the features of the gland with the features of hypothyroidism, this is moving toward a chronic type of thyroiditis, that is Hashimoto's thyroiditis, and the histopathology is only suggestive of the Ashkenazi cells. There is no mention of any vascular or uh, invasion, and this is classical of Hashimoto's disease. Yeah, Ashkenazi cells are present in Hurthal cell carcinoma. There is no doubt about that. Hurthal cell carcinoma is given that name because in the follicular carcinoma variant, you have the Hurthal cells, and that's why that is termed as Hurthal cell carcinoma. So here you are right to get confused, but if you evaluate the clinical scenario given, I will be giving this answer as Hashimoto's because of the hypothyroidism and the clinical presentation of the diffuse gland enlargement. In follicular cell carcinoma with a Hashimoto, with the Hurthal cell variant, will not have this feature. It will be a slightly different scenario. So don't get confused in this. Just because Ashkenazi, and this is why I told you that typically, definitively, the Ashkenazi cell has been mentioned in the Hurthle cell carcinoma in the follicular cell variant. But if you have read properly, we have mentioned all our notes that you are having Hashimoto's thyroiditis with Hurthle cells, and the Hurthle cells and the Ashkenazi cells go, the name is synonym. So remember this, okay? Yeah, no timeline given. Correct. Okay. So now moving on to the next question, that is, intubation is done for a patient for 30 days, and now it was done 1 year back. Now is presenting with respiratory symptoms, form swelling. Okay, form diffuse and large swelling is mentioned. Okay, not gland. It is a diffuse and large swelling. Okay. So yeah. So moving on to the next question, that is a patient with intubation does done for 30 days and which was done 1 year back now has respiratory symptoms. Yeah, the respiratory symptoms were stridor and dyspnea. Okay. Child. Okay. Child intubation for 30 days, 1 year back. Okay. With stridor dyspnea. Yeah, tracheal stenosis with stenting is one of the option. Yes. Yeah, I have mentioned here. So I think there are only two diseases diagnosis mentioned as tracheal stenosis or tracheomalacia, and the both were options were either stenting or the tracheal dissection and anastomosis. Now here I'll again point directly towards the Sebastian mention of this, which I've also clearly mentioned that benign tracheal stenosis is when you are having either history of either tracheostomy or ventilation tubes or history of trauma. Now, tracheomalacia will not fit into this picture because the patient has had a intubation done, which is a ventilation tube has been put. You have a cuff, and that will cause the mucosal ischemia, and you are having sandglass stenosis. Okay, so here the only definitive management would be a segmental dissection and the end-to-end anastomosis. Was the mention of intubation done for acid intake mentioned? Okay, no acid intake, right. So this straightforward again taken from Sabiston. Yeah, that was a different question, right? So we have also mentioned it again that any causes etiology is very important to understand. Classical management is definitive segmental dissection and end-to-end anastomosis. So here the answer would be tracheal stenosis as a diagnosis and do a tracheal dissection and anastomosis. Moving on to the next question, that is a known lung cell carcinoma patient present with Horner syndrome and radicular arm pain with spinal root levels are most likely involved. Is the question STEM and the options okay in this question? It was atypical lobe mass. Okay, atypical lobe mass with ptosis given. Okay, apical, right. C5, C6, C6, C7. Okay, C8, T1 was there. Okay, so it is basically a apical tumor with ptosis mentioned, with radicular arm pain mentioned, and ophthalmos. Okay, meiosis and ophthalmos ptosis, classical of Horner's. C8T1 question pointed towards reason for arm pain alone. Okay, and anhidrosis. So are the options correct now? That is C5, C6, C6, C7, C8, T1, and T2, T2, T3. Were this the options? Yeah, so now the options and question stem is very clear. A patient with a lung cell carcinoma presenting with a apical lobe tumor with ptosis, anophthalmosis, meiosis, anhidrosis, all pointing towards Horner syndrome, and there is a radicular arm pain. Options are as we have shown here. No, this is not C5, C6. If you have gone through either shorts or from our notes, you have clearly mentioned that this is classical of the Pancoast tumor or apical lobe tumor. There is Horner syndrome, that is classical presentation of ptosis, meiosis, facial anhidrosis, and there is a radicular arm pain, which is from invasion of T1 and occasionally C8. Okay. So if they had mentioned about the Horner's syndrome, that is because of the stellate ganglion, but because they have taken and mentioned about the root, that is most likely, as one of you have mentioned, that they had pointing towards radicular arm pain. Okay. So here the radicular arm pain is related to the T1 nerve involvement, and also we have also mentioned here that radicular pain with C8 T1 involvement is you need to rule out the Pancoast tumor, which is a apical lobe tumor. Okay, so here I think in the question and the options now it is very clear that the answer would be C8T1 as the correct one in this question. Okay. So I hope no queries. I think all the question and the options we have correctly recalled. So I'll just quickly go through the 11 questions what I've discussed right now. So and more other questions I'll be discussing tomorrow. So just to summarize for all the late joinees. So first question is about a patient with hyponatremia weakness with a paraneoplastic syndrome lung cancer as it is small cell lung carcinoma. Then you have a renal hilar injury with a history of trauma. Hemodynamically unstable patient. Incision used is always midline. Then triangle involved in subclavian artery and brachial plexus compression is a scalene triangle. Then you have the cleft lip unilateral answer is orbicularis oris. Not a management of thoracic duct injury, it is thoracic duct bypass. Not a criteria for ARDS, it is clinically right-sided heart failure. A 65-year-old patient, pneumoperitoneum, no high risk fever, left iliac fossa tenderness with 7 centimeter pelvic abscess. The answer is straightforward exploration, drainage, and Hartmann's procedure. 2 by 2 centimeter breast cyst with solid component that is pointing towards complex cyst, you go for core biopsy. 35-year-old diffuse swelling with cold intolerance, firm gland with weight gain pointing towards hypothyroidism with Hurthal cells or Ascanisis cells on HP. Answer is Hashimoto's disease. Child intubation done for 30 days before 1 year, now presenting with stridor dyspnea that is pointing towards tracheal stenosis. Answer is resection and anastomosis. Horner syndrome, that is anophthalmos, meiosis, anhidrosis for a apical lobe tumor or a lone lung cancer. Which spinal root is involved if the patient also has radicular arm pain? Answer is T1, C8 or C8, T1. So I think till now what we have seen is that all majority of the questions here were from Schwartz, and we have also clearly mentioned everything in our notes as well if you have not read the textbook. So it is very important that the NEET SS is moving towards coverage of all three books very thoroughly. So opinion of the paper, I feel that I have not yet reached the CTBS portion. Uh, Once I reach there, I'll be able to tell you more about the actual level of the paper, because till now, what questions I've seen is that it was this questions, 11 questions at least were pretty straightforward. But for me to comment more, I think once I am through the recall, I'll be able to tell you about the exact level of this paper. Yeah, I know the CTVS till now. What I have seen the preliminary screening, I think that it was tough, but don't worry. I'll try to provide as accurate recall as possible. See, I'm working even today. We have worked for the same, and I'll be trying to provide you with the detailed recall in the next maximum 1 2 days. That is my target. And I would be requiring help from you guys. Please contact me for any recall you guys have so that I can do it as soon as possible. So thank you all for joining. I'll be uploading this on the YouTube as well. Thank you.